This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Nancy Pead, who is the CEO of Peach County Regional Hospital. Is that correct?
Peach
Nancy?
Regional Medical Center.
Okay,
yes,
good. I got that. That's great. Well, welcome. So maybe we can talk a little bit tonight about what's happened in Peach County and in general, sort of some of the things that are going on in the American healthcare system. It's a rather small hospital, and just what exactly has transpired over the years at Peach County?
Well, we've been working since 2003 and trying to build a replacement hospital. Our hospital currently is about 54 years old. And the good news is we partnered with Central Georgia Health Systems and the Medical Center of Central Georgia, and we're looking to break ground on our new hospital March 29th. 2012, and we look to occupy the building summer of 2013.
Well, that's a good story, isn't it? So Peach County, let's see, so maybe you can talk a little bit about the history of the hospital. It was established some years ago, is that right?
We were established like in 1954. It's a Hill-Burton Hospital.
Right. Now, maybe you can talk about what a Hill-Burton Hospital is.
It was
what
just some funding that was needed to help community hospitals build their hospitals.
So this was government money that came to the
yes,
citizens of Peach County, and they established a hospital authority, is that correct?
They did.
And then with the money, they constructed a hospital.
They did.
Is that right? And it's been there for a long time.
Since 1954, yes.
And how have things gone over the years for the hospital? What has transpired since that time, ups and downs?
We've had some good times and bad times financially. It's kind of been a struggle for us, and we've looked for a while for a partner to try to help that out.
Now, why has it been a struggle? I mean, why would a hospital have a hard time? Is there, any reasons for that? Is it the payment mix of your patients, or what makes a hospital successful?
Yeah, it's probably a little bit of everything. It's probably the payer mix. We're predominantly paid by the government, Medicare and Medicaid, and they don't pay you a lot extra over cost.
Well, let's talk about a payment mix. What exactly? So I think that's something the public needs to know about. If a hospital might be a prosperous hospital if it has a lot of people with private insurance, is that correct?
That's correct.
And then if the hospital is looking after people of modest financial circumstances or older people, then the numbers don't work for that hospital.
It gets very, very difficult. And then we do more of the primary care type procedures, so we don't have high dollar procedures like hearts or things like that.
So really a lot of the things that happen in the American healthcare system are determined by the nuances of payment and different kinds of payment schedules. And how do those payment schedules originate? For instance, if someone comes in and a chest x-ray is ordered, maybe some amount of money is generated. And if a CT scan is ordered, another amount, and you need more CT scans than chest x-rays, is that right? Or can you discuss that?
That's about right, yeah. We literally, on some procedures and some lab tests, make just nickels and dimes and dollars on the tests after we pay for the cost and for the folks. So it just gets very hard to kind of keep the balance.
So in a way, these are fairly arbitrary, are they not? The payment regimen that exists in the American healthcare system has an arbitrary component to it.
It does.
Does it not? And the older tests might be not reimbursed so well.
Exactly.
And so if you're in a hospital that doesn't have access to really tertiary technology, it's pretty tough going.
It's hard. It's hard to make your numbers balance.
Yes, and so
we've done a lot of really good things. We've provided a lot of great care. We've stabilized folks and got them to the tertiary care hospitals. A lot of people still alive today because we're there.
So
we have a huge mission.
That's a big mission, and you're really, are you the only hospital in Peach County?
We're the only hospital in Peach County, and we serve Crawford and Taylor as well, and they don't have a hospital either.
So you have patients that just you come to the hospital. Do you have an emergency room?
We do. We have an emergency room.
Now, what does that mean when you have an emergency room? That's a big deal, isn't it?
It's a very big deal. We see about 15 to 18,000 over the years in our emergency room. We have basically 4 beds, 24/7
Yes.
staff with a physician.
Yes.
And we see all sorts of things.
And there are lots of legal requirements when you
Yes,
have
there
an
are.
emergency room. Do some hospitals try and avoid doing that? I mean, they call it, how do you avoid having an emergency room? You call it something else.
I think they may call it an urgent care.
Urgent care.
Try
Now,
to do
what's the
something
difference
differently.
between an emergency room and an urgent care? Is it possible to make a comment?
I'm not real sure.
I think, it might be, there's some obligations that an emergency room might have.
There
And
are.
I think they have to take all comers pretty much. Is that right?
You
Anybody
do.
that comes in there, you have to
You're
take.
obligated to treat and make sure and treat their emergencies if they come in. And
What
we
happened-
feel like that's our mission as well.
Sure, I can understand that. What happens if a patient comes in with a substantial problem in the emergency room and they might need tertiary care somewhere else? Is that a problem? I mean, we can name any kind of complicated case.
Sure.
Maybe a very sick person with a massive stroke. Maybe we can pick that out.
It can be difficult sometimes. What we would do is stabilize them, do what we can do, consult with another
Yes.
facility. Sometimes we have trouble finding beds because all the tertiary beds are occupied. And we will work to meet their needs with another facility and refer them there.
How would you do that? I mean, you're just on the phone calling people?
Yeah, pretty much. We really try to refer to the Medical Center of Central
Yes,
Georgia.
yes.
We have that relationship with them,
Yes.
so we go there first. If not, we go other places.
Yes, I will just make this hypothetical comment. One of the missions of the Trauma Commission in Georgia is to try and find a way to get
Right.
people where they need to go, and that could carry over, I think, all across the state for all kinds of
It can.
emergencies.
It
That's
can.
one of the big difficulties we have, isn't it?
It is.
That's a real problem. If somebody comes to an emergency room in a relatively small hospital, and they need really intensive care, there's not an easy system to get them there.
It can be difficult. And I think in our location in the state, we're lucky that the medical center is a primary
Yes.
trauma center.
Yes.
When you go south, there's
Yes.
absences of those hospitals.
Now the medical center is it's a big juggernaut, and I practice there. I know it's a big place and
It
a lot of
is.
tertiary care. How did it develop the relationship with Peach County? What happened exactly?
Back in the 90s, we had a management agreement with the medical center. So we've had a kind of a long history, and we are a critical access hospital, and because of that, we had to have a referral partner, part of the state designation. So we've kind of had a
So
relationship with the
every
medical
hospital,
center.
let's say a relatively small rural hospital, they have to get a relationship with a bigger
The
hospital.
critical access hospitals, yes, sir, they do.
Yes.
So we kind of, we've always been talking because we're trying to provide this care. We've tried to do some things that help us provide care at the standard they do at our
Yes,
place.
yes.
For instance, we developed what we call a rural heart network, and so they have given us all of their protocols to treat people presenting with chest pain in Fort Valley and Peach
Yes.
Regional. And then if we decide they need to be transferred, we can rapidly move them along.
Right. So one of the big things that could be out there, telemedicine, that sort of thing.
Yeah.
Do you have any your foot in that water
I
at all?
do, I do.
Well,
We have
maybe
a-
you can talk about that.
I'm excited about the
I
telemedicine.
can see that. We'll talk about telemedicine.
We have we had a grant through the state and the Georgia telemedicine partnership, and so we've got all the equipment that we need, and we're actually able to transmit images and probably heart rate and breath
Yes,
sounds
yes.
through the stethoscope to other consultants throughout the state, and get better care.
Yes.
And get their opinions and try to find
So
out
is that
what is
in,
the
is
best
that
course.
working now? Is that happening right now, or is it
We're
about
working
to?
on it in a smaller scale. We're working to develop it largely now.
Are you going to be able to send things like chest X-rays or CT scans, actually where the referring physician can see those
Yes,
pictures?
I believe it will take us a little bit of time to get
Yes.
there, but we will get there.
That would be a big deal, would it not?
It would
I
be
mean,
a very
it's a
big deal.
So,
It'd be a huge thing for the
yeah.
community.
Yes. So one of the things about improving the American healthcare system is the idea that there's a network of, care providers,
Right.
and you can immediately, no matter where you show up, you can have access to those care providers, and get on the spot decisions that would
Right.
be very useful. Yes.
Looking for right care at the right time and the right
Yes.
setting.
Yes. Yes. So maybe you could talk about the new hospital that's coming up, or how big is it going to be? How much did it cost? Maybe I can ask that. Is that a fair question? And what about it? Is it a very expensive, big thing to
We
do?
are very excited about, like I said, we've been working on this for many, many years now. Been planning it for a lot of time. Right now, we're still working on finalizing the budget. It's about $27 million.
That's a big number, $27
It's
million.
a big number,
Yes.
and it's going to be 25 beds.
Yes.
14 ER positions, so
Yes,
14 beds
yes.
there. We'll have 1 OR and 2 endo suites, and really just the basic services
Yes,
like we
yes,
need
yes.
now in an updated setting with more efficient workflows and the ability to expand, especially
Yes,
OR and
yes,
surgical
yes.
services.
Now, when do you plan to have this completed? What is your complete date?
We're going to break ground March 29th, and
Yes.
we're going to occupy the new facility, we think, summer of 13.
Wow, that's pretty fast, isn't it?
We've been working hard and fast to get this
I
going.
bet there's a lot of paperwork to do that. Is that correct?
You must have seen my office.
Is that an understatement?
It's an understatement.
And so that's and really just the complexities of paperwork often are daunting. I mean, it's unbelievable
It
how
is.
hard it is to do something in healthcare.
It is.
You have lots of regulatory bodies to go through and lots of different.
That's one of the reasons it's taken us this long.
How long has
not
it
been
taken
easy. We started planning in 2003.
Wow.
We
That's
bought the
9
land in
years.
2006.
Right,
And we've been
right.
really struggling trying to get the funding
Yes.
and all of the regulatory approvals since that time.
Yeah, how were you able to get the funding, or is that a secret?
It's not a secret. Our partnership with the medical center, they're committing to come help us build that
Yes,
hospital.
and so that'll be a useful thing for both institutions, I think.
Absolutely.
To be able to stabilize the patients. Now, how many people are employed at Peach County?
We have about 116 FTEs now, and we're looking probably once we go to the new hospital, increasing that to about 248.
Well, that's a big number, isn't it? That's a
It'll
lot.
be very good for Peach County and the surrounding areas. That'll be a very big business.
Yes, it
for
must
Peach.
be one of the in Peach County. That's a big deal, and for the neighboring
Right.
counties. Yes.
Yeah. Right
yes.
now we're about number 3 employer-wise, and we may move up a little bit
Yes,
once we
yes.
get that bump in employees.
Now, are you from Peach County? How did it happen that you came there? And maybe you could discuss your journey
Okay.
there and how you came to your present
Sure.
position. What happened exactly?
I'm actually from Brunswick, Georgia.
Well, Glenn County, that's a nice
Yes,
place there. Yes.
it is. It's great. And I have had some asthma when I was a kid, and I
Yes.
just wanted to do healthcare. And
Yes.
I went to the Medical College of Georgia, and I got a BS in respiratory therapy. And I
Yes.
kind of worked around a lot of hospitals, and I ended up at Peach as a respiratory therapist. And then when the medical center came to manage, they had some opportunity to get involved in stuff like quality and
Yes,
safety
yes,
and
yes,
joint commission.
yes.
And I just said,
So
can I
just-
help?
Now, maybe you can discuss what is the Joint Commission and what does it do, and if you had some interchanges with it. What
Yeah,
is the Joint
sure.
Commission?
Our hospital actually has been continuously accredited by the Joint Commission since we opened, so we're pretty proud of
Well,
that.
why is accreditation important? What does the Joint Commission do, and what should people know about?
Yeah, the Joint Commission is accrediting body for the hospital, and what that really means is that they come in and they make sure we meet certain quality standards and safety standards. And we have to meet the same standards as the large hospitals.
Yes.
So we're really proud that we've successfully done that.
And
all
so
these years.
a committee of visitors, they come
They'll have
and
2 or
look.
3 surveyors that'll come and they stay 2 or 3 days, depending
Yes.
on your size. It can be more or less.
Yes.
Right now, I think we have one that stays 2 days.
Yes.
When we were a little bit
Are
larger,
you a little
and had more
nervous
beds.
when these visitors arrive? Is that a little stressful, isn't it?
It could be stressful,
yes.
but they have been very good at helping point out things and opportunities that we have, maybe to do things better, and we've been very
Yes.
open to that.
And so actually it's been useful in many
It's
ways,
been
has
very
it not?
useful.
And what happens if you don't become accredited? Is that bad?
I don't think it's a good thing.
No, I mean, apparently you can't have Medicare patients, or
Yeah,
there's something.
I was
that
gonna
would-
say, a lot
it
of
would- it would be-
insurances won't.
It would terminate the hospital if
Yeah.
you, so it's a very powerful institution.
It is.
And it's pretty much every hospital in the state has the Joint Commission.
I
present.
think most of them do.
Do you think they're getting stricter as time has gone by, or they change? I think they started out more of just the place is reasonably sanitary, and have they gotten a little more over the years?
Mm-hmm. Yeah, I think they're looking more into the patient care processes and the experience of the patients and
Yes,
talking to
yes.
patients. And so I think they're moving into
Right.
where they need to be.
Right. Now, what do you think? Do you have any speculations about we have this huge change that's occurring in the American healthcare system with the way compensation occurs. We have the I guess the reformation led by President Obama. What do you think what's that going to do for your hospital? Have you thought about it? Is it going to make the numbers better or worse? Any thoughts?
We've thought about it a lot, and I think the one thing we knew is with all the change coming that we really needed to have a partner. We didn't need to be a small hospital out there in the sea of change all by ourselves. So I think we're taking steps to do what we need to do to have that partnership and be part of the system to be able to weather that change for sure.
And so some of the things that happen, I mean, you have all sorts of things that could happen to you. Is that correct? With different government regulations, things that are out there. What happens if you readmit a Medicare patient? Is that bad? I mean,
it can be.
I mean, what are some of the ways now that the government is having an impact on the way your hospital functions?
What they're wanting to do is pay you for quality, and by that, you know, they want to make sure that there are no complications or there are no readmissions.
So if you have no readmissions, the hospital's financial circumstances are better.
It should be,
So
yes.
what does it do? I mean, that makes you be very, what does that mean exactly?
I
Don't
think
send a patient out until they're really ready to go?
We just work really hard on getting the care coordinated. We do a fine job of that now, but we just work harder to make sure it's better quality care. We look at some more indicators, and we really have a few more eyes on things.
Yes. What are some things you monitor in regards to quality for your hospital? What are some things that you look at?
We monitor tons of things, but we really look at indicators for heart failure and pneumonia.
Yes.
You know, those are some of the core measures that are coming out, and we've actually been on the honor roll a couple times for having very good scores there.
What heart failure, what would you be doing about that? There are certain medicines that you want to be sure, you want those beta blockers on there and that?
Got to get that. You have to have the echo. You have to have the discharge instructions that really inform the patient on what they need to do when they go home so they can take better care of themselves. It's all very good medicine. It's just a little different way for us to do things, but we're embracing that part of it. I think it's good.
And, you know, one of the things we could say is if the American healthcare system, people find fault with it for one thing or another, but it does many, many things good. In many ways, it's getting better and better.
Yeah.
Is there a difficulty with patient compliance issues? In other words, the patients, do they always follow the instructions they receive?
I think that will always be a challenge because people have choices on how they want to live and what they want to do, and if they want to be compliant with their medicines. And it's always going to be a challenge, but you know, you work with your patients as best you can and try to get them to understand. Right, a lot of times if you just get them to understand and not talk the medicalese and get it down to their level, they can
be complicated. So when a patient leaves the hospital, how do you ensure that's what occurs? A person speaks to them? Do they sign something? Do they?
We do a lot. We really try to talk with them and educate them throughout their stay. So it starts at the beginning when they're first admitted.
Yes.
And then we really, really go over their discharge instructions with them line by line and get them to kind of tell us back, what are we saying to make sure they understand.
Yes.
We're working on implementing discharge phone calls, so we'll call them after that they get home to make sure they're taking their medicines and make sure they understand all the instructions, see if they have any questions, and that's proven to really, you know.
So you call the patients at home?
Yeah, we're working, yes, sir.
That's a pretty good thing, isn't it? I like that idea. That's pretty good.
Right now we're doing it in surgery only, but we're going to take it hospital-wide.
You know, I think that's a good thing to do, is a little extra attention. Sometimes that's an indicated thing.
Well, the studies say that they will ask you the question when you call them, and maybe they had a question about their medicine and didn't know how to take it. And it can really prevent readmissions or them not doing so well once they get home.
Yes. Now, the medical center is a big behemoth there. Have they been easy to deal with? How have you've so for a long time, the medical center has been giving some administrative support, and is that worked out okay? And what are the obligations each institution has as they have this relationship?
I think it has been a very nice partnership. I think there's been mutual respect on both sides, and you know, I know I don't understand the workings of a larger hospital, and they understand a smaller hospital is different. And I think we've been very good working those different kind of worlds together. So from my viewpoint, it's been a very good experience. I like the culture of the partnership, and they provided a lot of resources, a lot of, especially when us planning the new building.
Yes.
We are really looking for them to help us because they do a lot of building projects. So they've come and they've helped us.
Yes.
And when we're planning the ER, they'll have their ER folks come and say, you know, don't do this or this is a good thing to do. So we've got a lot of resources that we didn't have otherwise that have really come to play, especially with the designing of the building.
Now, is it is it a little bit easier to get your patients into the medical center than other hospitals, or any comments about that, or is it?
It has always been fairly easy.
Yes.
They've always worked with
Yes,
us the best
yes.
they could
Yes.
to get some of
Yes.
the patients in. Heart patients, OB patients have always been really easily
Yes,
transferred
yes,
to the medical
yes.
center.
You know, what about, one of the things I've observed is that many times it's difficult to get a patient transferred back to their, I guess, home institution. And there may be some kind of regulatory problems with that. I mean, can you speak to that? What, if you send a patient up to the medical center with a big problem, and then now it's time to, they've been stabilized, they're okay, they need maybe not as much care, or not as intensive care, and they might be a candidate to be transferred back. Are there some difficulties with doing that, or any?
I think there's some difficulties from the payment methodology. It doesn't really allow for that with how hospitals
Now that's a
are
big
paid.
deal, isn't it?
Yeah.
I mean, that if you think about some of the inefficiencies that are out there.
Yeah.
Now, just to ask this question, I mean, a person just that's involved with the healthcare system, many times there are these inefficiencies that appear.
Right.
And what do the people in Washington have to say about these inefficiencies? Do you have any comments about that?
Well, we talk to them, and
Do
we
they-
talk to our
does it
representatives.
do any good?
Sometimes it does.
Well,
Believe
that's a
it or
big
not.
problem, isn't it? So it doesn't, this is some of the, these government regulations often interfere with healthcare efficiency.
They can.
And that's an example of it.
It's a
so
good example.
If you take, whoever the payment is not appropriate for hospitals that take the patient back, is that correct? Are they paid? I mean, many times they would not be paid for it.
It's difficult how to split that payment, or who gets the lion's share of
Even
it.
though the appropriate thing is to be back in the smaller
Right.
hospital.
It does prohibit you from getting them in the right setting.
Yes. You know, I think one of the important things out there, something that concerns me, is tremendous government regulation, lots of rules being propagated, and the feedback that the government gets from institutions that are being affected by these different rules, to be able to say, this is a rule that doesn't seem reasonable.
Yeah.
I mean, it's just a little bit hard to get back to the government. I mean, is that a fair statement?
It's difficult. It's a fair
They
statement.
don't really listen to you much. Is that fair? Okay, all right.
You got to get the right person.
Well, okay. I mean,
I have had a win or two, but largely it is difficult to get all the way up to the people who actually make the regulations. You're right.
And with these regulations that are in the offing, I mean, it's a little bit, I mean, as an observer of the situation, it's a little worrisome. I mean, if we have a tremendous number of regulations that might be hatched out in a naive way. I mean, I use my words advisedly, naive, in that you know what the deal is, do you not, in your hospital? You know what the deal is.
Right.
And a decision maker in Bethesda, Maryland might not know exactly what the deal is.
Right.
And they're the people that might be making these regulations. And so it's an issue, isn't it?
It's an issue.
Well, I can hope that that doesn't have a negative impact, and we can get the system fixed. So let's see, what are some, I'd say, problems that you think are in the offing in the world? What are some problems you think are out there, the things that you joust with on a daily basis? What are things when you go into your desk tomorrow, what are you going to be worried about?
Right now where I'm at, we're really working with just the financial stability of the hospital and trying to make ends meet where we're at. It's just, it's, like I said, it's difficult there, so there's a lot of time spent there.
And that's pretty much referable to the payment mix, is it not?
It is. It kind of all ties in together, and regulations and what you can do and not do.
The regulations are expensive too, to comply with these regulations.
They are.
Do you have any idea how much complying with these needful regulations, how expensive that might be?
I don't have a dollar figure, but,
it's a
there's
substantial,
a lot.
It's a substantial amount, and sometimes the regulations are well intended, but maybe
I agree. I think they start off well, but then they get very broad, and I think that's what makes it difficult.
Maybe an extra fire extinguisher in each room. I mean, that's good to have fire extinguishers, but is there a limit to that? Well,
yeah, and probably the other thing we look at is recruitment and retention of staff.
Now, is there a problem with that?
There's just some shortages out there with some of the healthcare professionals.
What kind of shortages do you think you face?
RNs. We've had some difficulty recruiting pharmacists, physical therapists, respiratory therapists. There's really kind of a lot of them out there right now.
And you know, one of the things about the healthcare system, there's not any smooth way to get people created with these specialties. I mean, For instance, you're a respiratory therapist, or you started that way. How many respiratory therapists do we need, and are we producing enough, and is there a problem with that?
Yeah, I think there's shortages in a lot of that, especially as the population ages. We're going to be needing more and more folks to work in different areas of the healthcare arena. So I think that's going to compound.
How about making use of mid-level providers, PAs, nurse practitioners?
Yeah, we just hired one for our practice, so we're starting that. We haven't traditionally done that, but we have a mid-level physician's assistant working with one of my busiest doctors.
Yes.
So I think that's going to be very helpful for us to have him.
Yes. Is there a problem with recruiting? Fort Valley is a very nice place. Originally called Fox Valley, they tell me. Is that correct? It was called Fox Valley? And why did it turn into Fort Valley?
I'm not sure.
I think the story is apparently they misspelled. I'm sure someone
knows
out there the way they misspelled it, but initially Fox.
I've heard about it, but I don't know the story.
Well,
yet.
Is it difficult to recruit people to come to live there? I mean, it's a
bit
pleasant town.
difficult.
A little hard.
I think we're a little bit lucky from some other rural hospitals, as we're still pretty close to Macon.
Yes.
So some people who want that quality of life of a city can still go, fairly close to Macon. Some of the other rural hospitals that are really rural have really more trouble than I do, but it still is difficult.
What about recruiting doctors to come there? Is that a problem?
It's difficult. We're trying to get physicians, in the neighboring areas in Warner Robins and Macon and the surrounding area to work with us instead of having people to come in. We haven't had a lot of success in recruiting and getting people from other areas.
So one thing might be to have a clinic in the hospital to do that. That might be an effective way to do it.
Yeah.
And so you were mentioning some of the good things. Probably this $27 million hospital is going to be pretty good. Is that right?
It's going to be a great thing. We've been waiting on that for a while.
Wow. And the groundbreaking is when?
March 29th.
March 20th, that's coming up pretty soon.
It is. We'll have the groundbreaking from 1 to 2 out up the land on 247, and then we'll have a community health fair from 3 to 5 for the community just to come in and get some screenings and kind of monitor their health and celebrate with us what's coming.
And so is this a popularly known thing? Everyone knows this event's about to take place.
I think so, yes. We put it out there pretty much.
Well, good. I think let me congratulate you on the job that you're doing, and you're right in the forefront of the American healthcare system. Keep up the good work. It's been nice talking to you. Do you have any last observations you'd like to offer here?
Oh, none, but it was great being here. Thank you.
Well, thank you so much for coming.
Thank you.
We appreciate having you here.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.